Well, good afternoon and welcome to the webinar Tocilizumab in COVID-19, which clinical benefits. This seminar has been organized by the European Journal of Internal Medicine. What's the reason for this seminar? In the last few weeks, we have received 3 papers on this topic. I mean, the use of tocilizumab in the treatment of the COVID infection. And we also asked the deputy editor, Professor Levi, to prepare a commentary about. So the idea came to our mind of preparing a webinar in order to have the author of the papers sharing their experience and open their experience to a larger audience, larger than the reader of the journal. I hope you will enjoy. So let me tell you a few words about the agenda of the day. As I mentioned before, we are going to have 3 presentations made by the 3 authors of the papers. This will be preceded by a very short introduction that will be made by Dr. Giustozzi about the background of the studies. And then we will be hearing the results of the study presented by the authors. We will have a burning question immediately after each of the presentation. And then at the end, we will have the opportunity to have a larger discussion. So let me start with Dr. Giustozzi. Michela will provide you with a very short background about the use of tocilizumab in the COVID infection.
This slide summarizes the current evidence and all the history about COVID-19 disease, and I would like to thank Professor Mantovani from Humanitas in Milan for this slide. So everything starts with the interaction between the SARS-CoV-2 with the upper and lower respiratory tract and the replication of the virus into multiple organs. There is evidence that human sensor like tissue damage, toll-like reception may activate the cellular and humoral innate immunity, for example, the activation of the complement, and also the activation of T cells, and of course, B cells with the production of antibodies. All these 3 mechanisms can be impaired during COVID-19 disease and leading to an uncontrolled inflammation, defective or inappropriate T cells responses, or late antibody appearance. That means that we can observe 3 different syndromes. For example, the cytokine release syndrome, the macrophages activation syndrome, and the endothelial dysfunction determined to the coagulopathy associated COVID-19 disease. And in clinical terms, we can have a mild COVID-19 disease to a critical or more severe COVID-19 disease, indeed from pneumonia to acute respiratory distress syndrome and multi-organ failure. On the left of the slides, you can see the regulators of the COVID-19 disease. So first, the viral load. There is evidence that, for example, the viral load is lower in spring or summer compared to winter, or the concept of aging related to inflammation, so the concept of inflammaging, lifestyles, the association, for example, of smoke with COVID-19 disease is currently really debated, and the presence of gene polymorphism. As you can see, in each part of the slide, we can have different therapy that we can use in COVID-19 disease with a different target. For example, antiviral directly directed to the presence of the SARS-CoV-2, or the use of heparin for the coagulopathy associated COVID-19, the need of organ support, for example, the need of mechanical ventilation of, for example, the ECMO in multi-organ failure. But of course, we can discuss today about drugs that interfere with the cytokine release syndrome, such as glucocorticoids, anti-interleukin 6, anti-interleukin 1, and complement inhibitors. Let's see what happened in severe COVID-19 disease and what is the meaning of cytokine storm. First of all, the definition of severe COVID-19 disease is very heterogeneous among the study. Usually is defined as the composite of a patient who required the need of mechanical ventilation or intensive care unit admission or patient who died. In these patients, so patients with severe COVID-19 disease, usually there is a cytokine storm. So the presence of the virus into the lung determines the activation of macrophages, dendritic cells, lymphocytes that determine the activation and the overproduction of cytokines and chemokines. Particularly, there are three important and crucial cytokines, which are interleukin-1, interleukin-6, and tumor necrosis factor. Tocilizumab is a humanized monoclonal antibodies that blocks the receptor of interleukin-6. Why is so important to block the receptor of interleukin-6? Because there is evidence that increased level of interleukin-6 were significantly associated with an increased risk of death in patients admitted to the hospital with COVID-19 disease pneumonia. This is a study including 115 patients and confirm probably the hypothesis that mortality in this patient may be due to virally driven hyperinflammation. But not only increased level of interleukin-6 are associated with mortality, but in these meta-analyses, including in studies, increased levels of interleukin-6 were significantly associated with complicated COVID-19 disease, the need of intensive care unit admission, and with a more severe or critical COVID-19 disease. And tocilizumab, which is immune modulators that block the interleukin-6 reception, probably is a really important drug. This question with what is and what are the clinical benefits of tocilizumab in patients affected by COVID-19 disease will be discussed today in this webinar. Thank you.
Thank you, Michela. Thank you very much for your presentation. I think it's an extremely useful introduction for the pre-presentation, and actually was very useful in introducing us to the specific theme of the day. Now it's my pleasure to call to the virtual podium Professor Milazzo. Professor Milazzo works at the University in Milan, and more specifically at the Sacco hospital in Milan, that was very much in charge of several of these patients in the Milan area. Laura, please.
Thank you very much, Professor Agnelli. I'm waiting for my slides. Starting from this background assumption, at the Sacco hospital here in Milan, we also conducted an open-label single-arm prospective study to evaluate the clinical characteristics and outcome of patients hospitalized with confirmed and severe COVID-19 pneumonia and treated with off-label use of tocilizumab. Our primary outcomes were death and discharge from hospital over a 4 weeks observation. And secondary outcomes were a change in disease severity, grade, a change in oxygen support therapy, and a change in body temperature and inflammatory markers over a shorter time period of 7 days. We enrolled 51 patients with severe COVID-19 pneumonia, defined as a respiratory rate above 30 times per minute, and oxygen saturation below 93%, and a PaO2, FiO2 lower than 250. IL-6 plasma levels above 40 picograms per ml. Tocilizumab was given at either a fixed dose of 400 milligrams repeated after 12 hours, or in patients weighing more than 60 kilograms at a scheduled dose of 8 milligrams per kilograms of body weight repeated after 12 hours, not exceeding 800 milligrams per dose. Among our patients, 3.9% showed up with a moderate disease, 84% had a severe pneumonia, with 22 of them on continuous positive airway pressure, and 6 were critically severe on mechanical ventilation. 10 out of the 43 severe cases were eventually intubated after a median of 2 days following tocilizumab administration. And at the time of data censoring, 61% of patients had been discharged. In 67%, sorry, we observed a clinical improvement, and we had an overall mortality rate of 27%. The mortality rate was different, significantly different, when we stratified the population between those on invasive mechanical ventilation and those on non-invasive oxygen support, with a worse outcome in the former. We confirmed actually a very rapid and dramatic decrease of inflammatory symptoms and inflammatory markers, and like CRP, and we also saw an increase in lymphocyte and platelet counts. But after adjusting for the demographics and the time between onset of symptoms and tocilizumab administration, basal IL-6 levels, and to be on invasive ventilation at the time of treatment, only this latter variable was found to be independently associated with an increased risk of death. We finally observed a striking high rate of bloodstream infections over a median time of 11 days in 27% of patients, 86 of whom were actually hospitalized in ICU. So what can we finally infer from this data? We got to focus on the IL-6 pleiotropic effect that, as we heard before, exerts a very potent pro-inflammatory action, but with a lot of consequences, clinical consequences, but also is an immune modulating drug, both on innate and acquired immune system, promoting the differentiation and activation on B and T cells. So when we shut it down, we obtain an anti-inflammatory effect, but also an impact on immune regulation. And these double-edged sword effects must be taken into account when considering COVID-19 patients. And if we were able to confirm the anti-inflammatory effect, can we answer to the question about clinical efficacy? My answer actually is no, because of the lack of randomized control trial that does not allow to draw conclusive evaluation. About the safety, it's a bit easier. On the very short time period, we have a drug very well tolerated, while over a longer observation period, several authors reported high rate of secondary infections, particularly in critically ill patients. And the key question still open is the best timing of using this drug, because we must have a hyperproduction of cytokines even to consider the drug, but at the same time there is a point of no return for critically ill patients that do not benefit anymore from the drug. And let me just say one last comment, that is that even in a very emergency and overwhelming period like the one we lived recently, we shouldn't have forgotten the principles of evidence-based medicine and try with every strength to conduct a randomized control trial, even asking for help to the regulatory authorities that to make it easier for us to do that. Because now, besides all the data coming from different studies with different designs and different confounding factors, we are still not able to answer to this fundamental question. And this is my regret and my hope for the future. Thank you.
Thank you very much, Dr. Milazzo. Thank you very much, Laura, for this very interesting presentation. Very nice. Very nice to hear your data, and very nice also to hear your initial criticism about experimental design and what's need to be done for the future. So before moving to the next presentation, next speaker, I would like to ask Monica Solbiati. Monica is a member of the editorial board of the European Journal of Internal Medicine to make a comment and possibly to present a question to Dr. Milazzo about her presentation. Monica?
Thank you, Laura. That was really interesting. I have a question. Among the studies that we're going to listen from today, your study is the only one that included patients in the ICU.
Yeah.
After your experience, did you feel like you would treat more with tocilizumab the most serious patients, or rather the patients outside the ICU? What is your idea now?
Yeah, we are very critical on the use of this drug in very critical patients. At the beginning, we were moved to do that because of the criticity of patients and of the high level of IL-6 that we dosed at the very beginning. But after the onset of many bloodstream infections and a high mortality rate in those kind of patients, I'm very, very critical about that. But as I already said, it is very difficult to find the best timing. If you use it very, very, very early, you are probably overusing it and creating a situation of immune depression that is not requested. But you do not have to wait too long. Because when an immunological mechanism is triggered, and I think that Professor Dagna can teach us everything about that, it's too late. Probably it's too late, yeah. Thank you very much for the question.
Thank you.
So thank you very much, Laura, and thank you very much, Monica. I believe we had a very good start. I think this is indeed part of the story. To listen data, but also to have a critical comment about them. And it seems that you are very much prepared in making a very nice discussion about what we can achieve for this initial experience with this agent. Laura is actually a specialist in infectious medicine. And now we move to a different field because I'm going to call to the virtual podium Flavia Mattioli. She's a neurologist.
Hello.
She's a neurologist, so we are going to have a different point of view. She works in Brescia, and you might know that Brescia was one of the areas that was very much affected by the COVID infection. So I'm pretty sure that Flavia has a remarkable experience in the field, and we are very curious and anxious to listen her presentation. Flavia, please.
Thank you. Thank you very much. So, thank you very much to the organizers, and thank you very much to Professor Agnelli for this invitation. It's a pleasure for me really to share with all the audience the data obtained in this study, which was conducted in Brescia, of course, but specifically in the Montichiari Hospital, which is one of the Brescia areas hospital. As Professor Agnelli told before, we had a very great outbreak. You have to imagine that in Brescia we had approximately 3,000 patients admitted to the hospital. So it was a really hard work, and all these specialists were put together in order to give their expertise in the field. And the authors of this paper that I'm talking on behalf of are coming from different specialties. Of course, I am a neurologist. The first author is a neuroimmunologist, and there are, of course, specialists in internal medicine and aestheticians. So the next, let's move to the background that you have heard very nicely reported before. We focused on the point that there are two distinct but overlapping pathological stages that have been hypothesized in the COVID pneumonia. The first triggered by the virus itself, and in which possibly the antiviral therapy would be more useful, and the second one by the host hyperimmune response. And of course, we follow the first clinical observation taken from the Chinese experience that have shown that an improvement in pneumonia with severe respiratory distress in patients would be obtained with the use of tocilizumab. The next. So the rationale of our study was really to use tocilizumab with the aim to reduce the excessive immune response associated with the development of the irreversible lung damage, but before the need of mechanical ventilation. So before the appearance of a critical AER RDS. In our patient, no one at the baseline was intubated, and this probably is a critical difference between ours and the other study. And the second point, next, was to use a reduced dose of tocilizumab with the aim not to abolish completely the host response towards the virus or towards other pathogens. So in order to reduce the possible infections. And so our aim was, rather than suppress completely the interleukin-6 mediated response, to modulate it. So next, our is a retrospective observational study. We included 85 COVID-19 patients confirmed with the nasopharyngeal swab and with the chest X-ray. They all had a severe respiratory failure, so the same inclusion criteria as the others, so more than 30 respiratory X per minute, less than 93 saturation of oxygen in room air, or a ratio between PaO2 and VO2 lower than 300. But none of them, I repeat, was on mechanical ventilation. So we started using tocilizumab by March 13, when the drug was available in our hospital, and it was used only at a smaller dose compared to, for example, another study that was conducted in our hospital on more severe patients. They used 800 milligrams. So we only used 400 milligrams intravenously. And when we didn't have any more for 400 milligrams, we used subcutaneous administration. It was approximately 45% of the patients, of the treated group patients, which are 62 patients. So, to repeat, tocilizumab 40 milligrams intravenously or 324 milligrams subcutaneous plus standard care. And we used as control the retrospective controls of patients admitted to the same hospital before tocilizumab was available. They only were treated with the usual hydroxychloroquine and lopinavir and ritonavir. So the aim was to compare the mortality rates of tocilizumab versus controls and to study the clinical outcomes. And with this number of patients, 62 versus 23, we had a sufficient statistical power. The next, this is the clinical characteristic at the baseline of our patients. As you can see, the tocilizumab patients were slightly younger than the controls, but on the contrary, the controls had less coexisting comorbidities. For example, they had less hypertension, less diabetes, less earth disease, and they had less less level of CRP at admission. And we used also a trick suggested by the statistician. We included only tocilizumab patients admitted 4 days after the availability of the drug, and we exclude the control patient who were in the hospital 4 days before the admission. This is a quite interesting, and I will talk to you later, in order to avoid the bias that usually you have when you compare a control group with an active group without randomization. So the next one, this is the first result that we obtained, that is represented by a Kaplan-Meier curve with the Cox analysis. We found that tocilizumab patients had a significantly greater survival rate as compared to control patient, with a hazard ratio of 0.035, adjusting, and it's important, adjusting for baseline age, comorbidities, and CRP baseline levels. The next one, we didn't find any infection during the follow-up. That I know, it was not completed in this study, in this preliminary study. Not all the patients were discharged, but we are analyzing a larger sample of more than 150 patients between controls and tocilizumab patients, and still we don't have any infection. The next one, Also the infections were not observed and inferred by the observation that the procalcitonin levels did not change from the baseline to the end of the follow-up. The second result was the description of the clinical outcome that was really more favorable in the tocilizumab patients than in the controls. Tocilizumab data are in red, control data are in blue. So we have two findings. The first one related to the patient with the concluded outcome, that is died patient or discharged patients. They are 19 out of 23 controls and 55 out of 62 tocilizumab. So you, of course, will notice that not all the patients had the concluded follow-up in this first paper. But about tocilizumab patients who concluded the follow-up, only 2, that is only 8% died versus 95% who were completely recovered. And on the controls, on the other side, approximately 58 of the patients died and only 42 recovered. No, so the completely recovered in the tocilizumab group was 95%. The completely recovered in the control group was only 42%. And then move to the still hospitalized patient by April the 2nd. At April the 2nd, we stopped the data set of this first sample of patients, and we analyzed the clinical course of these patients by scoring their respiratory condition in terms of improvement, stabilization, or worsening. For example, we scored as improved a patient if in that observation he needed less respiratory support. For example, he moved from the CPAP to the mask or from the nasal flow to normal air, room air breathing, or if he in spontaneous breathing he improved his artery oxygen pressure. And we, on the other side, we scored as worsened. You will see in the next figure. The patient has, now come back, please. Come back, okay. And we scored as worsened if the patient needed heavier respiratory support. So here is the number of the observation, that is the number of the days in which we found an improved condition or a worsened condition, again in the controls or in the tocilizumab patients. And you can see that in tocilizumab patients, which are in red, more than 64% of the observation resulted improved in the follow-up, and only 27% worsened. And on the other end, the 10%, 100% of the control patient worsened. Instead, in fact, they were all on mechanical ventilation. And the next picture is graphically representing this observation. You will see the green bars, which refers to the improved observation, the white bars referring to the stable condition, and the red bars to the worsened condition. The first with the T are each patient in the tocilizumab group, and the last 4 in the graph, in the blue graph, are the controls. And all the controls were on mechanical ventilation, whereas you can also visually see that the green bars are more extended than the red bars. And the last slide, please. To conclude, we can see that single low dose tocilizumab in patients with COVID-19 pneumonia in the relatively early phase of the respiratory distress, that is a severe respiratory distress without mechanical ventilation, significantly reduces the mortality and improves the clinical outcome compared to standard treatment. We can also say that single low dose tocilizumab is not associated with infections or other side effects. And interestingly, subcutaneous administration may be considered as an easy and effective therapy for the future. Of course, these are preliminary data and need to be confirmed by randomized clinical trial, but in our opinion are quite convincing. Thank you.
This was a very nice and clear talk that I'm pretty sure it will provoke quite a number of questions. And I'm actually seeing several questions on the screen. Let me suggest you to make the question as sharp and short as possible, because some of them are very long and difficult to read. So my suggestion to the audience, please make your question very direct and simple. Before moving to the third and last presentation, I would like to ask Monica to comment and to present a question to Flavia. Monica, please.
Thank you, Flavia. Thank you. I have a question. Most of the patients in the Tocilizumab group were still admitted to hospital at the end of the study. I guess you're going to give some more information about them. Do you have any data you can share today with us on these patients to see if their data are consistent with the patients that completed the follow-up in the study?
Unfortunately, I didn't take here the last paper that is under revision. It includes, of course, all the follow-up. But what can I do? Can I tell you is that at 30 days, they at the end of the follow-up of 30 days, they were discharged and they were no more on any type of respiratory support. So, of course, the follow-up is positive also for longer follow-up, and it will be hopefully published. Now it's under revision. Thank you.
Okay.
Very, very important comment. Let me anticipate that the journal is now receiving several papers on the long-term outcome of these patients. And to be honest, I think this is one of the most intriguing parts of the story. So I would encourage you and people in the audience to submit papers, possibly good papers, in order to have the full picture, you know, the outcome at the very beginning, in the middle, and possibly also at the end of the hospital stay, and in other words, in the follow-up. As you have seen, the questions are reproduced on the screen. So this is another reason, you know, in order to have them as short as possible.
So what about the steroids? We didn't use any steroid therapy. It's a point that we can go into deeper later, but we didn't use any steroids. And from the audience, what about why have not implemented a double arm cross-check study to test Tocilizumab? Of course, we would like to, but you have to imagine the pressure and the hard work that it was. So I absolutely agree that it is better to use Tocilizumab, but the preliminary data that we had prompted us to continue using Tocilizumab instead of making and organizing a double blind. And nowadays we don't have any more patients, of course, so as I think all of you, so we cannot do any other double blind. And
Flavia, let's stop, Flavia. Let's stop the question to you here, and we will be back. We have lots of time for the discussion. We heard the presentation of a specialist in infectious disease. We had a neurologist. Now we move to internal medicine, although very much oriented toward immunology, but still internal medicine, Lorenzo. And Lorenzo Dagna is, again, a professor of internal medicine at the Raffaele University and Hospital in Milan. We are very, very curious and anxious to listen to your presentation, Lorenzo. So please go ahead.
Thank you very much, Giancarlo. So this is the study, and we analyzed and studied a patient with COVID-19 in the context of a general observational protocol that was approved by the ethical committee that actually not only acquires and analyzes data on all patients that are admitted to the hospital or to the emergency room, but also biobank them. So we're building up a significant biobank study, biospecimen study at admission, at discharge, and possibly at also different time points for and also after discharge, for analyzing many aspects that are still open about COVID-19 epidemics. At the time of the study, which was barely middle March, first days of April, standard of care was here shown. So patients were treated with hydroxychloroquine, with a combination of lopinavir and ritonavir. They received, if they were admitted from the outside of the hospital, a combination of ceftriaxone and azithromycin. Azithromycin was given until a negative antigen for Legionella was found out to be negative. And also those patients, those were the day when we started speaking about the hemorrhagic complications. So all the patients analyzed in this study received prophylactic exposure. So we included patients that had a swab that was positive for SARS-CoV-2 infection in RCT or scan or X-ray showing from imaging, and also they needed to be on supplementary oxygen, so either a reduction of the concentration of the in there or less than 300 millimeters of mercury. We asked that in the presence of any elevated level of lactate dehydrogenase showing inflammation of the lung indirectly, and in the presence of inflammation that was determined by either an increase in CRP that was more than 100 milligrams per liter or severity that was more than 9%. We exclude patients in the specific trial when they showed evidence of concomitant infection. They should have specific contraindication to if they had an elevation of liver function tests, or if they were treated concomitantly or recently with other immunosuppressive biologics. In neither patient nor controls, any corticosteroids was allowed. At that specific time of the pandemic, data were emerging suggesting not to use, let's say, intermediate dose, which means 20 to 80 milligrams of methylprednisolone equivalent per day, since it seems that it was of no benefit. So no patient was on corticosteroids. Tocilizumab in our protocol was given more or less according to what was proposed for China from China's scientists. So we gave it at a dose, an intravenous dose of 400 mg, followed by a second dose if within 24 hours the patient showed worsening of respiratory function, as defined by the need to increase the fraction of inhaled oxygen, the need to start a new non-invasive ventilation, or the need to start a new mechanical ventilation. These are the characteristics of the patient. We actually enrolled into the trial 32 patients that were treated with tocilizumab and 33 patients that were receiving just standard treatment. As we have discussed, this is not a randomized control study, but all the patients were admitted were actually, patients that didn't receive tocilizumab didn't receive the drug mainly due to drug shortage. So they were patients that met the inclusion and exclusion criteria, but they wasn't treated with tocilizumab because at the time of admission or deterioration, the drug was not available. And as you can see, actually the patients were quite severe. No, sorry, go back. As you can see, the median PA to FiO2 ratio was 107 in tocilizumab patient and 124 in the control group. So there were clearly patients that have significant respiratory insufficiency, and also they were inflamed, febrile, and whatever. These are the results that we have, and as you can see here, actually patients in the tocilizumab group showed, they died less numerically, but this difference could not reach when testing with the Fisher exact test, the two curves. And the same thing, weren't able to show an actual and statistically significant improvement of a clinical improvement when we compared actual controls to tocilizumab treated patients. What we could see is that there was a significant difference in clinical improvement in tocilizumab patient according to the baseline level of the PaO2 to FiO2 ratio. So patient that had a ratio that was greater than 100 did definitely better and quicker than patient having a PO2/FiO2 ratio of less than 100. And the same, probably there's a mistake in my slide because one slide is missing, but believe me, the same observation could be made if you actually subdivide patient on the base of their age. So if they have an age of greater than 70, they showed a worse outcome if compared to patient being younger than the patient that we consider in the analysis. So to conclude quickly, we can spend a couple of words about safety, and we have a serious adverse effect in patients from both of the group, and the number of severe effects were actually comparable in the two groups. But what we saw was that specifically patient that was admitted to the ICU, and this is something in perfect agreement with what the colleague before me just said. So when patient was admitted to the ICU, the risk that this bacteremia and then this infection could become a serious infection and sepsis was so elevated, and in many cases, in many patients, determined the death of the patient. So actually, although the rate of infection was less worrying, was more or less the same in the two groups. Actually, when patients treated with tocilizumab got infected, they have, on average, a worse outcome than what was seen for other patients if the patient were in the ICU. We didn't see many differences in the rate of pulmonary thrombosis or thromboembolism between the two populations of patients, and we saw the same level of increase in transaminase in liver function tests in the two subgroups, letting us thought that probably the major determinant in the setting of hepatics or liver sufferance is more the combination of antiviral drug than actually the treatment with tocilizumab itself. We saw patients with transitory neutropenia in at least 5 patients with tocilizumab, and in no patient treated with a standard group, but in no patient the neutrophil count was less than 1,000, and there was no specific signal of worry from this neutropenia. So to conclude, we saw, although some promising results could be showing there, we didn't see any statistical difference between tocilizumab and standard of care in our cohort of patients. We saw bacterial and fungal infection in roughly 12% of those patients, both in the tocilizumab-treated patient and the control group, and this was more relevant in terms of clinical outcome in the tocilizumab-treated patient. Clearly, those numbers are small, and we would be needing the ongoing trial to confirm both efficacy and safety in the whole population, but our preliminary data showed that probably this drug is not what the wonder drug that somehow was discussed earlier in the story. And I thank you for your attention.
Well done, Lorenzo. Very well done. Very well done. Very, very interesting. I think your presentation also will be the reason for several questions, but let me start with Monica. Monica, you go first.
Thank you, Lorenzo. That was very interesting. In your study, you said that the duration of symptoms was unrelated to the clinical outcomes you observed, and this was discussed before, and probably other studies and all the other discussants said that probably the right timing and early treatment might be beneficial. What's your opinion on this?
Yeah, my idea is that definitely, and I think that is one of the things that actually this epidemic taught us, and if, finger crossed, nothing will be happening, will be one of the things that will be adding added information to our strategy, is that the earlier we treat the patient, the better outcome we have. From a selfish, trialistic point of view, treating earlier the patient will be probably resulting in a larger number needed to treat in order to show a signal. And since most of the patients that are treated earlier will go for a better outcome independently. I know that anecdote medicine is not the one that will be driving results in clinical medicine, but I think that being with colleagues that probably have personally treated a number of COVID patients, they can share with me this opinion. I got a patient that it was a 68, 69-year-old male, hypertensive with a lot of risk factor for COVID-19 pneumonia, who developed hyperinflammation and hypooxygenation. We offer him to be treated with hydroxychloroquine. He refused. We treated him, we offered a treatment with lopinavir, ritonavir, he refused. He got more inflamed, and then we offered him to be treated with tocilizumab, he refused. This patient was discharged 5 days later on room air. Whatever treatment we would have given to this patient would be adjudicated as a success. And this patient independently for everything would go out. So randomized control trial are needed. I had a nice discussion with Dr. Aguet from France that was speaking at Euler a couple of days ago, showing us the huge effort that France has done with randomized control trial. The problem is that they will be having the results by July. So, and probably and hopefully by July, we don't need much of this information. So I think that the studies that have been presented here are of protein importance, but we need to be extremely cautious when interpreting all those data, because again, this disease has taught us something. One, if you treat it earlier, probably you get very good results. Second, if you don't randomize, you risk to be extremely imprecise.
Well, very, very nice. We have now enough time for the discussion. Before going to individual question, I really would like to have a general question to the three of you. And it was alluded to by Flavia, if I do remember well. And this is the use of steroids. So this is the question for the three of you. How do you feel steroids should be used in this specific setting? Who go first? Laura, you go first.
Okay. We didn't use steroids in our patients, as Professor Dagna said, because of the warning about using it in COVID-19 from the IFA and the regulatory authorities. But I think that like in sepsis and in septic shock, there is possibly a place even for steroids, but it's very difficult to find out when. And the problem in this disease is that when we use steroids in sepsis, for example, we use it with antibiotics. So we are fighting from two sides. Here, we do not have at the moment an efficient antiviral. So we are the risk is to give an immunosuppressant to patients with an infection without even knowing how much the virus is still doing to the lungs and to the organisms. So it's very, very dangerous. I think that there is a place, but we do not, which is now. No, I'm speaking for me, of course.
So, Flavia, would you like to add
For me, it's exactly the same. We didn't use at all steroids in our population, Just to answer the question, our population maybe in the control group was quite older than the Tocilizumab group, and that's why probably the mortality rates were a little bit higher than what expected. But for this reason also, we didn't use any steroids, because the steroid, has been told before, a critical mechanism on the immune response against the virus, and they reduces, as far as we know as neurologists, but also the other colleagues, the population of lymphocytes, for example, CD8 lymphocytes, which are important for antiviral response. And so I think that using an immunomodulating drug at small doses probably is more effective than use a steroid itself. We had our first author who was very expert of immunomodulation in the PML, that is quite rare but severe side effect of the use of natalizumab therapy. And we observed that using steroids is not effective because you contemporarily have the iris, which is a hyperimmune response, and contemporarily you have the virus, which is working in the brain. So using the steroids revealed to be absolutely negative.
Lorenzo, anything to add?
Yeah, no, I think that steroid treatment could be useful and probably with a double-edged aspect. So I would say that I think that probably a low dose of corticosteroids very early in the course of the disease may be beneficial. Clearly enough, this is pure skin and or gut feeling. It's not been demonstrated by any randomized controlled trial. But probably a lower dose of corticosteroids may be helpful in controlling the earliest phases of the disease and then the transition into the hyperinflammatory phase. And we have data from rheumatological patients that received a chronic low-dose corticosteroids that actually were maybe 95-year-old or so with the rheumatic condition and being on 10 milligrams of prednisone daily. They didn't develop any form of pneumonia and they recovered quickly from the disease. So probably a low dose of corticosteroids is enough. I'm quite convinced that an intermediate dose of corticosteroids when you have the hyperinflammation phase is not helpful. I think it should be investigated higher dose, namely maybe 1 gram or 500 milligrams of corticosteroids in the hyperinflamed phase, but this absolutely raised what Dr. Milazzo said before, raised the need of protecting probably the patient with an antiviral. And as far as I'm concerned, we do not have an antiviral, including ritonavir, including remdesivir, that is clearly helpful for the disease so far. So clearly it will be a harm, because I agree with what Dr. Mattioli say. If you block a single cytokine, you probably don't impair that much the immune response to virus, unless you block interferon gamma, probably. But when you use corticosteroids, or to some extent, this is my personal opinion, again, JAK inhibitors, you risk to go broad, and that could be more detrimental.
So I have some individual questions. I mean, some questions directed to some of you, but before going to this part of the discussion, let me ask another general question, possibly just one of you could answer. Could you tell the audience, could you give the audience a scenario of the ongoing study with this agent in this specific clinical setting? In other words, what people is doing around the world and what we could expect in the coming months. Are you informed, Laura? I mean, what people is doing around?
Yeah, I know that even in Italy, promoted by IFA, there are randomized control trials with the use of tocilizumab in this setting. Unfortunately, the epidemics, or fortunately, I will say, the epidemic is slowing down. So it would be a little bit difficult to find the numerosity we asked for. But I know that there are. The strange thing is that Italy, USA and China are at the moment the only countries using widely this approach.
Well, thank you very much. So let me go now to some individual questions, and then I know that Monica has got quite some of them left, so she will help me after a while. So the first question is actually for you, Laura. I was saying Laura, but then Laura. So the point is you have a mortality rate of 47.8% in the control group. So somebody from the audience is asking, well, how do you explain such a high rate of death in your control population?
No, this is a question I put to Flavia, actually. We had a 27% mortality overall, and we do not have a control group. So, because considering that they didn't have any mechanically ventilated patients, my question is, why in the control group there is such a huge rate of mortality. It's astonishing. Maybe because of the historical period in Brescia with an epidemics going so overwhelming and making it very difficult even to mechanically ventilate patients. I don't know.
I'm not sure I understood all that because the connection went away. But the question is why we had such a high mortality rate in the controls. As I told you before, probably they were the historical, the first ones that were admitted, and so the outbreak was so had such a great pressure. But you have to imagine that in the Montichiari Hospital, as I am seeing now, the mean mortality in those wards, which are, how you call geriatry or internal medicine, it's around 33%, and we had with COVID the controls 47%. As I told you, this is quite a lot, but anyway, I think it was because they were older than Tocilizumab. They were the first. Maybe they were treated differently. They didn't got all the drugs that later in the course of the recruitment the other patients had.
Yeah. Monica, I understand you have a question for Lorenzo about the absence of reduction in mortality and the reason for that, sample size versus a specific effect. Lorenzo, do you understand the question?
I feel that it's clearly also a question of a sample size. So if you have, we saw a kind of difference and was quite a clear trend. And also there's a biological plausibility of the treatment. I also can tell you that after this result, we tried to move our research to other immunosuppressive molecules, and some of them have already been published. Some of them are coming out in the very next days. The general impression that I have is that probably something that is shared with my colleagues, so that specifically in critical patients and in patients that either on admission or later in the course, they would be needing mechanical ventilation, this treatment risks to be a little bit harmful, specifically for infectious complication. What we saw is that many patients that I show you also in my data, they got at least bacteremia during mechanical ventilation. And this is probably due to a mix-up of mechanical ventilation per se and the damage of the alveolar barrier in the lung of those patients, which somehow predisposed them to a quite different ecological environment, microbiological environment than what you typically see in the ICU. So if those patients are immune suppressed with a drug as Tocilizumab, or in general with interleukin-6 blockade, and I can tell you that we have comparable data with the other anti-interleukin-6 agent, Sarilumab, you have either an immune suppressive effect. Second, you have an immune suppression that lasts more than, for example, with other immune suppressors such as anakinra that have a short half-life and then they could be taken out. And third, you have a significant effect also on CRP, which is one of the markers that the clinician used to detect and suspect infection. And since the patient is intubated, is probably a febrile due to Tocilizumab, is no raise in the CRP. Also, there's as an impaired immune system, there's a combination of things that make difficult to diagnose and treat and recognize promptly the infection that maybe result ultimately in an increased death. So I'm quite convinced, to get back to the very first answer, that probably if we increase the number of treated patients, we get a signal. But again, I'm not saying something specific, but if you need to increase too much the number to get a signal, probably the magnitude of the signal is not that much.
So I have now
I just wanted to add that in all the other two studies, really the higher rate of infections was in the ICU, and also was with higher doses of tocilizumab. I'm talking about Laura series. And what do you think, I'm asking you, what do you think about our subcutaneous administration, which revealed to be very easy and probably less effective than less high, less concentrated. We reached less concentration than the 400s, but it revealed to be very useful, and maybe in the future could be more easily administered in those patients, for example, with a respiratory distress with a ratio PF of between 100 and 200. Our patients were, of course, milder than the Sacco series. Our mean PF ratio was about 190. So probably they are less severe than yours, but maybe in this series, a 324 subcutaneous injection may be useful, and we've heard and we have studied that it gives the same. I know if it's correct, the same saturation of receptors of the interleukin-6. The subcutaneous administration. So maybe it is useful.
Yes, I agree. When we get in shortage of tocilizumab intravenously, but the study was still concluded, we also tried to use the subcutaneous format. We did not see any differences. So I agree that it might be a good option in the case that the drug would result in a good outcome for the patients.
Well, I have a question about the cytokine plasma level, not just interleukin-6, but all of them, all of them that we know, of course. Do you have any data about the time course of the cytokine level during the study, during the administration of tocilizumab?
We have some data, but again, tocilizumab treatment since it's a drug that blocks the receptor and not the cytokine itself, you expect to have a huge raise in the level of the cytokine immediately after administration. That will be going down more or less slowly depending on the loading dose. And it has been shown that the increase of interleukin-6 that you measure is not related, do not correlate with the efficacy and of the effect of the drug itself. One of the things that we saw, I don't know if the same observation that you have, is that pre-treatment interleukin-6 level do not predict at all the response. So there are a number of patients that has low level of interleukin-6 at baseline and they respond perfectly. Other patients that have elevated level of interleukin-6 which doesn't respond at all. So it's not predictive, neither being, let's say, an earlier predictor nor as a follow-up side effect.
Yeah. So Lorenzo, in other words, the level is not predictive of the outcome, and the time course during the administration is not predictive of the outcome again. Correct?
Exactly.
I think it is important because people could do the mistake of measuring this cytokine while there is no reason of doing that. This
is in our hand at least. I don't know if the colleagues confirm that.
Well, we consider to have IL-6 levels above 40 milligrams picograms per ml as inclusion criteria based on the results from Chinese cohorts that put IL-6 basal levels as a outcome related to a worse outcome. So we started only in patients with high levels of IL-6. So I cannot say what would happen in those with lower levels. It has no reason to measure the IL-6 levels over the treatment because it tends to raise, as Professor Dagna for sure know that. So it's not there is not a relationship between the raise of the cytokines during the treatment. Yeah, but as a basal value, we decided to measure it. Yeah.
Well, I have a fancy, I would say, a practical question from the audience, and this is about the potential shortage of tocilizumab. So the question is, have you ever gone short of tocilizumab? In that case, would have been using? Is there an alternative in the same direction, or you simply stopped?
We didn't have this problem. We moved to the subcutaneous administration. I don't know what would we do if we were short.
My personal feeling is, sorry.
Go ahead.
Go.
Laura. My personal feeling, Laura, go ahead, please.
No. I did the same. We did the same. We switched to the subcutaneous at the first time, and then we stopped.
Lorenzo?
Yeah, my comment is that I think that in general, we have a lot of discussion also for other drugs, that the general thought was that you need a very high plasma concentration in order to enter the lung and pass all this material that has been accumulated into the lung and blah, blah, blah. I think that this is purely theoretical. So I mean, we have no evidence. Speaking calmly 2 months after the pandemic, in saying that we really need the peak of concentration, and the data that Flavia has just presented are in perfect agreement with this thought. So probably we need a certain dose. Probably the circulating cytokines are quite important to be neutralized, and probably again we have no data showing that at least when they are alive, those patients has a pulmonary histology that is identical to a classical ARDS. So with membranes, with something that could be an obstacle to passive diffusion of the drug into the lung. So I think that we made a lot of mess, sorry for the word, about finding out elevated level of the drug. I gave an example. Since, for example, Sarilumab is not available as a IV drug, you need to physically inject the sub-Q formulation into a bag of saline and then administer this to the patient. Probably giving the shot sub-Q wouldn't have been that different. I'm convinced after a couple of months. Again, those data have not been proved. A trial should be done in order to show that. But the general clinical feeling from my side is that we made a lot of discussion about probably nothing. So the drug itself is, even if it's bioavailable a couple of hours later, it doesn't make much of a difference.
Well, I have several questions about the concomitant use of steroids, but I do believe that we have covered this topic indeed. So I know Monica has several questions for the speaker. Monica, could you pick up some of them and present it to the speakers?
Yes, sure. Something has already been addressed, I guess. I would like to ask Dr. Mattioli, in your study, patients in the tocilizumab group were younger and more inflamed than patients in the control group. As you already mentioned, the earlier patients were probably older. But do you think that the more inflamed patients had much more benefit from the treatment?
It is possible. Yes, of course, it is possible. The survival rate curves seem to say this, but of course we need to test this hypothesis with different stages and more patients. What I can tell you that in the second paper that we are preparing, the differences between the treated and the untreated is still more significant. So possibly the patients who are more have more inflammation have really taken really much advantage to the treatment with tocilizumab.
Monica?
I have one more question to all the speakers, if it's possible. You mentioned different rates of infectious complications. Do you think this might be due to the different way you measured infections? Some of you measured procalcitonin, some others looked at bloodstream infections. So do you think besides the different kind of patients, also the way you looked for infection was different, and this might explain differences in complications?
Possibly. In our study, of course, we had milder patients. We controlled the chest X-ray. We controlled for the blood tests and for fever and for CRP, but probably we didn't go into details. But for the patients who were discharged, for sure we didn't have any other infections. We checked for procalcitonin, but probably there are more specific investigation that you could do. This was a preliminary report that, as I told you.
Well,
yeah. Yes, we searched for secondary infections with a routinely matter with surveillance swabs and cultures, bloodstream cultures. So it was perhaps easier in ICU, particularly, to find out that. Yeah.
Mm-hmm. No, our data were on bacteria that have been cultured actively, and isolated actively. So this is the reason for which we may be a little bit more conservative.
Yeah. So I'm sorry, I have an additional question about the steroids. I have actually many, but I think I cannot get rid of this one here. The question is why corticosteroids should not work in some situations if tocilizumab actually do. So there is an explanation.
In some?
Why in some patients these agents work and it's not the case? You see the question on the screen.
Okay, sure.
Why shouldn't work?
It's a matter of dose, in my personal opinion. So, and this is the reason for which I commented that probably corticosteroids could be useful, but at a dose that, in my personal opinion, could be harmful to the patient being infected with a virus. So I agree with this question, which is perfect, but I personally think that if I want to get the same immune suppression that I see acutely after a single shot of 8 milligrams per kilo of tocilizumab, I would be probably needing to give 500 mg of prednisolone, or even more in 1 or 2 or 3 repeated doses. Then I'm quite convinced that I would be seeing the same effect. The only point is, on one side, I was worried, and I'm still worried, to block one cytokine. Giving this dose of steroids when a patient is actively infected with a virus, at least it is theoretically a point that worries me. Again, theoretically, maybe there are some safety signals, but I agree with you.
Can I ask something to Lorenzo about this issue? Do you think that corticosteroids compared to tocilizumab are more easily manageable? I mean, the half-life of tocilizumab is quite long, and it's difficult to come back. With the corticosteroids, maybe it's easier to stop it or to modulate.
Yeah, but the genomic effect of 500 to 100 mg of corticosteroids will last longer. So clearly enough, you can stop the drug, but you have genomic effects on the population. And also, we don't know what is happening to lymphocytes on those patients. Some say that they are exhausted, some say that they are just pulled into the lung, some say a lot of things. But again, my major concern would be that by paralyzing the entire immune system with such doses of corticosteroids, probably you risk to have viral determined effect. Again, it's something which is not being proved at all, and maybe it will be working perfectly without any problem for the patient, but still is a little bit worrying to me.
And also there are the series from Hong Kong patients who reported more hallucination and more diabetes, so probably more complications in patients treated with steroids compared to those not treated.
Well, this is something that should be taken into account.
Sure.
I would like to leave finally the opportunity to each of you to present questions to the other speaker. But before doing that, could you give me an idea, a clinical idea? I'm not talking about detailed data. Let's say from a clinician to clinicians. What's your idea right now about the safety of this approach? I know that you need a randomized clinical trial, you need the control, you need to assess the efficacy. But apart from this, what's your feeling about the safety? I'm talking about your clinical idea. If you have data, that's fine, but I guess the number is not enough. So you as a clinician, you have a mature idea about the safety. What's yours? You go first. Laura, you go first.
Okay. Well, in the absence of antivirals, efficient antivirals, I'm quite scared about using it again in these patients, because I agree that if I would use it very early, probably it wouldn't be harmful, but probably either not useful. And in more advanced patients, I'm scared. I gotta be.
Any other opinion about the general safety?
In our opinion, probably we used a smaller dose compared to the other two studies, and we had less severe patients. So we tried to intersect to pick the patients who were deteriorating, but who didn't still need mechanical ventilation. Probably if you take those selected group of patients, it is really safe, particularly if you use the subcutaneous low dose.
Yeah. Lorenzo, any additional?
Yeah, I think that one of the options that should be explored is go sub-Q, and probably even earlier than we did. So and again, knowing that you won't be ever getting a result from an RCT with this kind of population, because you probably would be need to treat 10,000 patients in order to get the signal.
Yeah,
because so many patients in this condition will get better. Yeah. But I think that as far as I'm also a clinical immunologist, as you pointed out, we have quite a good safety signal from patients taking biologics that got infected with COVID. And they in most of the cases, they didn't develop an extremely severe disease. The treatment was stopped for a moment, and then it was set again back in the treatment schedule without complications. So again, I think I'm very worried about interleukin-6 blockade late in the course of the disease. So I won't be suggesting that I would be preferring other mechanism of action, possibly. And I think it should be considered maybe a little bit earlier, or even in the very prodromic phase. I'm quite convinced that if you give interleukin-6 blockade to a patient that is in the viremic phase, that will not be affecting that much the outcome. Okay, and another important question, however, we have to point out, and also this should be studied, is if interleukin-6 blockade would be imbalancing the antibody production. Because you know that the interleukin-6 blockade is one of the major drivers of the transition into memory B cells and then into plasma cells. So there's a theoretical risk that patients treated with an interleukin-6 blocking agent may have less of a memory response and less of a B cells and a humoral response against the virus, a long-standing immune response. This is something, again, that should be checked, but should be, again, taken in consideration when you pick up a different mechanism of action.
Well, some additional questions about the use of steroids are coming, but I would like to stop here and to give you the option to present question to the other speaker. So if there is something that you would like to have clearer, and now there is the opportunity for you, the three of you, to present question to your colleagues. Anyone? Anyone? Everything is clear? Everything is clear?
I would like to ask the colleagues if they are planning to put together their results in order to, for example, obtain a sort of, not a meta-analysis, but something more robust in the, for example, in the results in the selected groups of patients, because, you know, for example, Sacco patients are more severe than our patients, and Raffaele patients are in between. Probably we could reach more results by putting together the data, because, you know, the inclusion criteria were quite similar, and also the outcomes.
I believe this would be a great idea. I would encourage you to, you know, with the limitations of the experimental design of the study, I mean the differences in the experimental design, I think we should do some efforts to have this data together. We will sum up to about 200 patients or more. So I think it's a good lesson for the reader. And I would also suggest you to publish this report in a good journal. I'm not saying to So any other question? Laura, do you have any question from
Yeah.
Flavia?
Yeah, there is again about the best timing, if there is one, for using this drug, because I heard now about the possibility to use Tocilizumab earlier, but we based our studies on the hypothesis of a cytokine storm, cytokine release syndrome, and to treat it with this drug. It is as if we wanted to treat, for example, with antivirals, the flu syndrome, to influenza. If I treat all the influenza with antivirals, I probably obtain a very high rate of response, but most of them would have go well anyway. Will recover anyway. So it's very difficult to find out how to manage the timing of this drug. And I don't think that the answer is to start earlier. I think that we should know much more about the virology of this disease. Where is the virus? How much? Which is the burden? How much is it is replicating? To know which is the right patient to treat.
Yeah, absolutely. And also, I think that we should understand why, again, you have 90 and so year old person that goes home without a major problem, and you have the 18-year-old boy that has been that received lung transplantation for devastating COVID-19 pneumonia, and apparently this guy was and this guy was without risk factor. So there's clearly a huge indication in finding out the right person to be treated, who needs to be treated, who should be at risk. So an earlier treatment should be implemented. Maybe something will be coming out from genetic studies. I feel that, I don't know, Giancarlo, if you have a different opinion on that, but probably a lot come from epigenetics also. There's a nice work from scientists and physicians from the Netherlands that are that are working on the trained immunity hypothesis connected to the virus. So there probably some kind of vaccination also can enhance the antiviral response, not in a classical immunological, let's say, mimicry, but just because they influence the innate response to the virus itself. So, for example, there's been a program in Holland vaccinating with Bacille Calmette-Guerin all the population in order to prevent the development of COVID-19. So again, we need to have more information, and we need to understand who need to be treated.
Yeah.
Having said that, I still think that a low dose of immune suppression or anti-inflammation in general, we have just published a small case series of patients treated with colchicine that aborted apparently inflammation in a limited number of patients. There was a larger series published a couple of days ago from Italy about that. So there are a lot of things that should be put in place, and I think this kind of immune suppressor probably should be taken in consideration in patients that are early but are clearly moving towards a severe disease.
So I understand at the end of this discussion that we need to discuss about the drug, but having heard the opinion of some members of the authorities, I think it's important. It's extremely important that we define properly the patients and the time when we are treating this patient, because otherwise we could get the conclusion that A is effective or not, but it is mainly due to the type of patient and when the patient was treated. So this is quite a concern of the authorities. I spoke with them, and they say, well, if a report comes and they say it is effective, then the question is who and when it was administered. So it is something that, unfortunately, this infection is not like MI or PE. You have the clinical presentation, and you make treatment. In this particular condition, you have a very long period of the start of the disease and the presentation. So I think it's a quite complicated thing. So my last point, any additional and further thought you have about this meeting? This is open to everybody, to all of you, and Monica and Michela. I mean, do you have any last final comment about this afternoon?
Just a comment that comes into my mind. Well, if the frequency of infection is linked to the higher dosages, and in the Sacco series, the higher dosage did not show a greater efficacy than the smaller dose. So why isn't this a point where to start with?
Yeah, I think it's a good point, and probably let's get the very last question. I think Lorenzo has already answered such a question, but just in case, I think the question is very specific, and the guy said, well, come on, several people are working in the field around the world. Are you talking with these people? Do you have sharing of ideas with these people, or everybody is working by himself or herself? So there is a framework of people working on the same field. Are you in touch with these people? Not every day, but once in a while. So there is a real framework of people working on the same topic, or everybody is going along toward the final target. Lorenzo, are you talking, or Flavia? Are you talking, or Laura? Are you talking with your friends in France or in UK that are doing the same? I think this is essential at this stage. Do you have a framework? Do you have a continuous flow of idea with these people around the world?
Well, if I can answer, I think that's the course of the epidemic didn't help us in this exchange of ideas, because we came first, and the epidemics is now, I hope, stopping here, and it started elsewhere. So we didn't share at the same time the same protocols, and so we have a lot of studies with different designs and no connection, and this is why I'm waiting for the randomized control trials that are probably the only one that can give us some more information.
Yeah. Yep. So this seems to be a very reasonable conclusion. So you might be surprised, but we have been talking for 1 hour and 45 minutes. So we are getting to the limit for a human being to pay attention to something.
To a webinar.
Right.
With some exception I'm not going to mention here, but I think we are getting close to the limits of the attention of people listening. So I really would like to thank you all for your outstanding presentation, but for your standing participation in the discussion. It was really very instructive to me. So I'd like to thank the speakers. This is Flavia, Laura, and Lorenzo. Let me say thanks especially to the organizer. I'm talking about Silvia Molosio, and the colleagues, the staff of the SMC Media that did a very, very good job. So thank you very much. This is one of the first initiative of the European Journal of Internal Medicine. We will check the outcome, the results. I don't know how many people were actually connected. I believe we will be able to have such an information, and we would like to do this type of activity once in a while. We need to discuss about whether this will be done every 2 months or 3 months or every month. It depends by the interest of people. But for the time being, thank you very much for your brilliant presentation and for making such an extremely live discussion. Thank you, friends. Thank you very much.
Thank you. Bye-bye. Thank you to all of you.
Thank you, the audience, for attending.
Ciao.
You don't see them, so probably we have been talking the six of us. You never know, but just in case there is somebody in the audience, thank you very much for attending. Thank you very much.
Thank you. Bye. Thank you very much.
It was a pleasure.